Hello, everybody. Welcome to the United Leukodystrophy Foundation's virtual family conference session on PMD, presented by Dr. Wolf and Dr. Tanduti. This session is being recorded and will be posted for viewing online in early July. Thank you so much for joining us. Now I will turn it over to Dr. Wolf.
Thank you so much, Tara, for introducing me and also for inviting me to speak here at the PMD session. Welcome, everyone. Just to give you a little bit of overview on my background, there are no conflicts of interest. I'm working in the Amsterdam Leukodystrophy Center, headed by Mario van der Knaap, and we are actually a center really doing translational research. So we work a lot with, of course, with patients, clinical findings, natural history, disease evolution, and MRI analysis. We also define new leukodystrophies and their causal genes. We have a very active pathology department and do quite advanced studies on brains donated by patients and families, which is very important for understanding disease mechanisms. We have mouse models, and recently we started also initiating treatment trials for leukodystrophies. And we care for patients with all leukodystrophies, but we also have some disorders we focus on. And this is vanishing white matter is a large focus, and that's actually led by Mario van der Knaap, X-linked adrenoleukodystrophy by Mark Engelin, and hypomyelination and metachromatic leukodystrophy, which is my focus of interest. So that's also the reason why I'm presenting today. And because I'm also rather involved in the new trial for vanishing white matter, I will leave the session after the questions because there is a vanishing white matter symposium also going on in parallel. So I'm sorry about that. This is part of our team before Corona, when we still could stand closely together. And a lot of young people actually you see here, which are who are very enthusiastic PhD students and lab technicians, which is very nice, of course. So PELIZAEUS-MERZBACHER disease has all to do with myelination, and normal myelination actually happens in the more or less in the first 2 years of life. A new baby doesn't have much myelin, especially only the brainstem and some small areas of the brain, but you see that at the age of 2 years, all these black areas are myelinated. And that process is actually not working well in PELIZAEUS-MERZBACHER disease. So what is myelin? It's produced by cells we call oligodendrocytes. And myelin are membrane wrappings, which are wrapped around the nerve processes, which we call axons. And myelin consists mainly of fat, also of some proteins. And PLP1, which is important for PELIZAEUS-MERZBACHER, is the most important one. And first, those myelin sheaths are quite loose, and they are then actually compacted, becoming very dense. And this is something also going on in development of myelin, which we call maturation. So normal myelination can be followed on MRI, and it's actually not only oligodendrocytes, but you need all brain cell types. You need astrocytes to provide fatty acids, microglia to provide certain factors helping with myelination. You need some signals from the nerve fibers to initiate myelination, and of course also some factors coming from blood. And it's actually amazing because when an oligodendrocyte starts to make those big sheets of myelin, which are wrapped around the axons, that means an increase in surface area of about 6,500-fold. that's huge. And that happens within only a few hours, so very fast. So we can follow that process beautifully on MRI, as you see here, from a newborn baby until the age of 2 years. And you see how the white matter signal actually changes. That also means that we can use MRI to see how much myelin is there in a child. And when we have hypomyelination or a deficit in myelin, you see that the MRI of a child with hypomyelination looks very much like the MRI of a newborn baby, because you have this very white or black, depending on the kind of image you make, white matter signal, which is actually the contrary in normal children, in healthy children. So myelin is the insulation material of the nerve fibers, myelination, the process of making myelin and wrapping nerve fibers, and hypomyelination means myelin deficit. Myelin is also present in peripheral nerves, and it's needed for the fast information transmission, or we call that saltatory impulse conduction, but also for the protection of the nerve fiber of the axon and for the nourishment of the axon. There are a lot of disorders of myelination, a lot of hypomyelinating leukodystrophies, and PELIZAEUS-MERZBACHER disease is the most frequent one, at least in the Netherlands, and I believe also in most other countries. It's been described a long time ago by a neurologist from Germany in 1885, and he described already very nicely the X-linked inheritance, although that concept wasn't known at that time. And Dr. Merzbacher, he was a pathologist. He studied brains of that family and actually described already the lack of myelin. So the setting in the Netherlands in our Center for PELIZAEUS-MERZBACHER disease, more or less all Dutch patients are referred to the Amsterdam Leukodystrophy Center. They visit 1 to 4 times yearly, depending on age, and are seen by us, but also if necessary by pediatrician, physiatrist, spasticity team. And we also take charge of adult patients, which is actually very nice, because recently I saw 2 cousins, 30 and 40 years old, with the classic PELIZAEUS-MERZBACHER disease. And it's good for us child neurologists also to see how the disease evolution in adulthood is. It's very rare. So we have about 17 million of people, 170,000 births per year. And I would say we have 1 to 2 new patients per year. So it's a rare leukodystrophy. The clinical presentation is in the classical presentation, early onset or conatal pendular nystagmus, those wobbly eye movements, decreased muscle tone with problems with head control, followed by spasticity, ataxia, dystonia, and intellectual disability, although that's much less severe than motor impairment, and very, very variable in between patients. Sitting without support in the classical form is usually not possible. The clinical course, we see developmental progress in the first years of life, and then followed by a stable phase, and then usually end of the first decade, beginning of the second decade, we see, unfortunately, a slow deterioration with progression of spasticity, increasing dysphagia, secondary complications of severe handicap. Peripheral nerve involvement is rare, only with the selected gene changes, and life expectancy is very difficult to predict, but usually more than 20 years. So what's actually important is this slow deterioration phase, which we see in those patients after a very stable phase. And you could ask yourself, why is that? Because of the lack of myelin is there. So why does it change? We think that the lack of myelin actually makes the axon, so the very thin and long nerve fiber, more vulnerable to all kind of influences, because also axon nourishment, axon protection is not so well. So axons actually die, and that means increasing spasticity and so on. So the deterioration we see in the patients. PELIZAEUS-MERZBACHER disease is caused by changes in the PLP1 gene, which encodes the most abundant, the most important myelin protein, which is expressed in the oligodendrocytes. There are two different forms of PLP1, a longer one and a shorter one. The most frequent gene change is a duplication of the entire gene. And then we have all kinds of other mutations affecting very different amino acids. And for many of them, it's quite difficult to predict when we see an amino acid change, what kind of PELIZAEUS-MERZBACHER disease we will have, a milder form or a more severe form. The consequences of different PLP1 mutations are different. Missense mutations, for example, are thought to be stuck in a part of the cell, which then actually decompensates, and the oligodendrocyte actually dies very, very early in development. When we have a duplication of the gene, we think that a lot of the PLP gene protein is actually stuck in some of the small parts of the cell we call lysosomes or endosomes. And there will be also trapping of lipids in those endosomes, which also leads to arrest of oligodendrocyte development and no myelin produced. I alluded already to the fact that the clinical spectrum of PELIZAEUS-MERZBACHER disease is very wide, from very severe forms with the conatal stridor, severe hypotonia, and no motor milestones, until a mild form with only a relatively mild spasticity being evident a little bit later in life. Also keep in mind that women, mothers of boys with PELIZAEUS-MERZBACHER disease, can develop symptoms usually when the boy isn't affected as severely, so only with mild mutations. This is a bit counterintuitive, but that's actually the case. And we see actually quite important symptoms as a slowly progressive spasticity, but especially urinary incontinence, which can make life very difficult. As a basic rule, if you have a mild form of PELIZAEUS-MERZBACHER disease, you have more myelin than in a severe form of PELIZAEUS-MERZBACHER disease. And when we look, we developed a score together with the Inga Harting, a neuroradiologist for PELIZAEUS-MERZBACHER disease. And we see that in the very severe forms, we really have less myelin than in the classic forms. And in the milder forms, we have more myelin again. At the moment, we only have symptomatic treatment for PELIZAEUS-MERZBACHER disease. The problems of developing causal treatment is that PELIZAEUS-MERZBACHER disease is really an ultra-rare disease. Mouse models are available already for quite a long time, but experience has shown that not all data in mouse are relevant for humans, and not all treatments that work in mice work in humans. Unfortunately, we have learned that also from other disorders. There is a lack of natural history data, and those data are needed to decide whether a treatment works or not, because you need a comparison group. There are different mechanisms of pathology with different mutations, not only one factor. And of course, you can try to approach a disease individually, like correcting the individual gene defect, but there are probably also global disease mechanisms which might need another approach, like inflammation or the axonal health. So I think Dr. Tenduti will talk about that part in his talk. There have been already efforts, and I think you all know about that, about intracerebral transplantation of neuronal precursor cells to provide a healthy oligodendrocyte pool. There have been tried other factors, cholesterol, curcumin, ketogenic diet, and so on, in animal models. And there are efforts actually to start a study with antisense nucleotides, so a form of gene therapy where we try to decrease the elevated gene dosage in patients who have the duplication of the PLP1. And there you have to be very careful not to knock out PLP1 completely, because you really do need PLP1 to function properly. I showed those slides last year too, and because of the COVID, this was very, very much delayed, but we have made some progress, so it will start. A small study, I have to say, which will actually test a medication called deferiprone, because a group of colleagues, David Deutsch and Marius Wernick, have actually found that in PELIZAEUS MERZBACHER patient cells, there were changes of protein involved in iron metabolism, which we call ferroptosis. Gene correction normalized those changes, but also treatment with the medication used for patients with certain blood disorders was successful in cell cultures of PMD, oligodendrocytes, and also PMD mice. Those iron chelators, deferiprone, are used for the treatment of certain blood disorders which necessitate a lot of blood transfusion. They scavenge iron. The medication is used in adults and children, but it's not registered for young children. And the medication also has some side effects, especially nausea, vomiting, and a very serious side effect, a decrease of the white blood cells, which actually means a risk of life-threatening bacterial infections. So that's something you really have to monitor very carefully. The study will take 12 months per patient. We look at the change in motor function and at myelination on brain MRI. We also will look at blood and CSF levels of certain markers. And for a patient, it means MRI scan at start, at the end, and spinal taps at start and at the end, a small skin biopsy, and weekly capillary blood tests to check for this white blood cells, which is a dangerous side effect, and 3 monthly visits to Amsterdam for a physical examination and more detailed blood tests. So why do you do a study, not only give the medication? You really would like to see, to evaluate the real effects of this treatment. And even in a study, it's already very difficult. Which patients will be included? Patients up to the age of 7 years, the severe forms, and patients with point mutations, not with the duplications, because for the duplications, we expect the gene correction trial coming at some point, which will need patients without other treatment. And at the beginning, we don't want to include older patients because they already have axonal damage. And that's not something you can actually treat by additional myelin. And milder patients have better motor development and myelination anyway. So in the milder patients, it would be very difficult to separate this from possible treatment effects. And the question is whether it's possible at all to start myelination later on in life. That has been very much debated. because you could actually argue it's a kind of a window for myelination in the first years of life. We learned something from another group of patients with hypomyelination. We actually saw at a young age, and those patients look very much like PELIZAEUS-MERZBACHER disease. Also their MRIs up to the age of almost 1.5 years. And when you compare that with the normal myelination, you see a clear difference at that age. Those patients actually continued actually to develop very well, which was quite surprising for us. And when we repeated MRIs, we saw that myelination actually did start and was almost normal in the older patients. So I think that's very encouraging, because it shows that myelination is not only possible in the first 2 years of life. So to summarize, PELIZAEUS-MERZBACHER disease is a disorder with varying severity. Female patients are identified more frequently now. So female patients with symptoms, there's more information about natural history needed, and that's in the study in CHOP, where we also contribute patients to. We developed a MRI scoring system, which will be useful for clinical studies and retrospective natural history studies. MRI biomarkers might be interesting because there are new MRI methods where you can quantify myelin quite nicely, and also look at axonal function, which is important for PELIZAEUS-MERZBACHER disease. It's still unknown whether there are other good blood or CSF biomarkers. Treatments are not yet available, but clinical studies are starting. The deferiprone, the gene reduction study, and you will hear from Dr. Tonduti about his efforts. And I think treatment approaches for older and milder patients should be aimed also at axonal health. So those are most of the people we collaborate with on hypomyelination and also PELIZAEUS-MERZBACHER disease. And I would like to thank you and all colleagues around the world, and many others who help with our efforts. So thank you very much.
Well, thank you, Dr. Wolf. That was an excellent presentation. If anyone has any questions, you may type them in the chat or use the hand raise option located under the reactions button at the bottom of your screen. We have a couple minutes if you have any questions before we move on to Dr. Tonduti's presentation. There is a question. Could you share about the experience of identifying a therapy that worked in a mouse model and then did not work in humans?
Okay, thank you. Well, you could say the transplantation treatment didn't work in humans. You can argue that it was only 4 boys who were treated and you didn't know the number of cells to transplant. But that's an example. We have other leukodystrophies where we gave, one gave, for example, enzyme replacement or a certain kind of gene therapy, which seemed to work in dogs even, but not in humans. It just didn't work. So I think we still don't know so much about, for example, gene therapy and its effects on certain brain cells, or the possibility of medications to cross the blood-brain barrier, the dose of medications. That's still an issue, and it will be it will continue like that. That not everything which is looking very well in animal models will work in patients. And it's a process we all have to go through, I think.
Was there any more questions? Oh. Okay, if there are no further questions, I think we will move on to Dr. Tanduti.
Thank you so much. Bye-bye.
Thank you.
Today and to have the opportunity to talk to you about PELIZAEUS MERZBACHER disease, new therapeutic approaches, and particularly about ketogenic diet. These are my disclosures. As you all know, PELIZAEUS MERZBACHER disease is an X-linked recessive disorder, which is due to mutation on PLP1 gene. PLP1 codified for the proteolipid protein 1, which is one of the main components of the myelin. Myelin is the part of white matter that constitute the sheet around the axon, allowing the fast conduction of electrical impulse throughout the axons. The classic phenotype is characterized by onset during the first months of life with nystagmus, trunk hypotonia, developmental delay for limb spasticity, cerebellar signs, and in some cases also movement disorders. Beside the classic phenotype, we know that there are some patients who present earlier with a more severe phenotype, and we also know that PLP1 mutation are cause also of milder presentations and phenotypes. There is a genotype-phenotype correlation, and so depending on the type of genetic alteration, we can observe different clinical presentation. This is the typical MRI pattern of distribution of abnormalities, and for those who are familiar with MRI, it will appear quite clear that this 11-year-old boy have a pattern of hypomyelination, of diffuse hypomyelination. The classic phenotype, as we said, has usually onset during the first months of life, and it correlates with a pattern of hypomyelination on MRI, which means lack of myelin. If during the first years of life, the clinical picture usually remain quite stable and the patients present a quite improving clinical picture, subsequently, when patients reach the adolescence, deterioration often start, and it correlates with the progressive cerebral atrophy on MRI, and it is thought to be due to a second, or at least in part, to a secondary axonal damage. Currently, there are not a definitive cure for the disease, and treatment is mainly symptomatic and supportive. However, there are some new therapeutic approaches that are under investigation. One of them is the use of antisense oligonucleotides. Nicole Wolf has talked to you about iron chelation, and I will spend some more minutes talking to you about ketogenic diet. What is ketogenic diet? Ketogenic diet is a normocaloric diet with high intake of lipids and low intake of carbohydrates and protein. And this resembles a prolonged fasting. Ketogenic actually means the depletion of a whole class of nutrients, namely carbohydrates. This condition promotes the synthesis of ketones as energetic substrates for the central nervous system instead of glucose. This In this cartoon, you can see a representation of what I said. This is the blood-brain barrier. In normal condition, glucose can enter, cross the blood-brain barrier and enter in the central nervous system and is metabolized in order to produce ATP, which is the main source of energy in a human body, by mitochondria. In fasting conditions, so when we have low concentration of glucose in our blood, we can use fat to produce energy, but fat cannot enter and cannot cross the blood-brain barrier, so they are converted in ketones. Ketones can enter the central nervous system, where they are metabolized to produce ATP. So they represent an alternative source of energy instead of glucose, and they are usually exploited by the brain in fasting conditions. Fasting has been used as antiepileptic treatment for centuries. So in the first half of the 20th century, there has been some clinical reports describing ketogenic diet as a possible treatment for epilepsy. After that, in the second half of the 20th century, there has been the discovery of a big number of new antiepileptic drugs. So this is called the new antiepileptic drugs era. And so the interest for ketogenic diet significantly lowered. Since the 1990s, a renewed interest for ketogenic diet grew up because of the increasing evidence of efficacy in clinical observations. And during the 21st century, we saw a number of new trials demonstrating that ketogenic diet can be used as an efficient treatment for epileptic seizures. Actually, we still don't know the precise mechanism of action of ketogenic diet. There are a number of hypotheses, there are different and many new data, but we still don't know precisely which is the mechanism through which ketogenic diet is effective on seizures. But if in 2009 there were insufficient class 1 evidence for the majority of the clinical management issues regarding ketogenic diet, conversely, in 2018, we had enough clinical trial allowing to say that ketogenic diet is a valid, scientifically based treatment for epilepsy. And so now there are a number of different epilepsy syndromes and different conditions for which ketogenic diet has been reported as beneficial for the control of epileptic seizures. Moreover, in recent years, there is a growing interest about ketogenic diet and its usefulness for a number of neurodegenerative disorders. So it has been proposed as a possible therapeutic approach, usable also in, or which has to be considered also for Parkinson's disease, Huntington disease, amyotrophic lateral sclerosis, Alzheimer's disease, stroke, multiple sclerosis. So there are a number of research that are considering and are investigating its usefulness for these disorders. Not all patients and not all people can follow a ketogenic regimen, there are a number of conditions which it is contraindicated, because ketogenic diet can influence the normal metabolic processes which are impaired in some diseases. So there are a number of contraindications that have to be ruled out before starting ketogenic. For what is now the current state of the art, we do have to consider both short-term and long-term side effects. If in the past also immediate side effects at initiation were a concern, they are not present anymore after new protocol introduction. For what concerns short-term side effects, weight loss and alterations of bowel habits are the main ones. But it has been demonstrated that with an optimal diet control, they can be reduced to zero. Instead, we have discordant data about long-term side effects. We do need large case series with long-term follow-up for more precise understanding. Anyway, the strict follow-up recommended copes with possible metabolic and nutritional side effects. For all this reason, we have to follow patients in a very strict way. Ketogenic diet is not something that can be followed by anyone without any control. Conversely, it has been really closely monitored by a multidisciplinary team. To start ketogenic diet, there is a first phase of preparation, which is mainly focused on the exclusion of any contraindication to start the treatment. After that, there is an initiation phase in which, after the first baseline exams, and once all contraindication has been rolled out, the regimen is started with an increasing ratio between fats and carbohydrate plus protein. Following the initiation phase, there is the treatment phase in which patients are followed up, and there is a continued monitoring of both the positive effect of the treatment and also the possible side effects of the diet. And this is just to show you the list of examinations that have to be done during regimen follow-up. The typical ketogenic diet plan for a 5-year-old patient. But going back to why we started to consider ketogenic diet as a possible treatment for PELIZAEUS-MERZBACHER disease. What we know from literature is that PLP overexpression leads to an endoplasmic reticulum stress, and moreover, hypomyelinated or unmyelinated axons usually suffer from an energy deficit, and they try to recover from it, increasing the number of mitochondria, which appears to be abnormally shaped. Moreover, we know that the myelination triggers inflammatory responses involving the production of reactive oxygen and nitrogen species. As we said before, we know only partially why which is the mechanism through which ketogenic therapy is effective in controlling and reducing epileptic seizure frequency. But we know that it is able to enhance the mitochondrial function, and it is able to decrease reactive oxygen species and DNA damage. On this nice paper from Sina Stumpf and Jessin Saher from the Göttingen group in Germany, they tried ketogenic diet on a PMD mouse model, and they observed that treated mouse showed myelination improvement, but most of all, a reduction of axonal damage with rescue of mitochondrial abnormalities. Moreover, they were able also to observe an improvement of motor function in the affected mouse. Based on all this data, at my institution in Milano, Italy, in collaboration with Bambino Gesù Hospital in Rome, again in Italy, we decided to start a clinical trial with ketogenic diet in PELIZAEUS MERZBACHER disease. And we did it in strict collaboration with the group of Göttingen. So we are about to start the clinical trial, which will last 24 months. Inclusion criteria will be mutation-proven PMD or HAMS, and obviously all patients in which we will find any contraindication for the ketogenic diet will be necessarily excluded from the trial. The outcome measures will be the outcome will be measured through a number of different tools, namely standardized neurocognitive scales, standardized functional outcome scales, for sure brain MRI, evoked potential, and some blood biomarker that I'm not allowed to talk to you about now. At the same time, in parallel, for sure, we'll have to monitor the safety of the ketogenic diet through a number of different evaluation, clinical and biochemical. I just want to take a few more seconds to thank the whole group and the whole medical staff who work with me at the neurology service in my institution in Milano. I also want to thank the group of doctors, therapists, and medical professionals who work with me at the Center for Leukodystrophies we created about 1 year ago. And finally, I have to thank also Dr. Bertini and Dr. Nicita, who work at the Bambino Gesù Hospital in Rome, with whom we collaborate a lot, not only for PELIZAEUS MERZBACHER disease, but also for all the other leukodystrophies. Thank you very much for your attention. And I'm here if you have any question.
Okay, thank you, Dr. Tanudi. That was another excellent presentation. If anybody has any questions for him, they can type it in the chat, or feel free to turn on your video. You can use the raise hand option.
I changed the room in the meantime.
Yeah.
Room and the haircut also.
Yeah, you did. It's like magic. Well, we do have a couple minutes left. Well, you just must have had a very thorough presentation.
That's great. I'm very happy.
Let's see. Well,
Okay.
okay. Well, if there are no questions, I just want to thank you so much, and all of our speakers, our sponsors, our audience, for making the virtual family conference this year a possibility. And I really hope to see everybody in person next year. That would be amazing.
Thank you very much.
Thank you. Okay. I think we're going to end it.
Goodbye. Thank you.
Bye.